Welcome back, Focus Learners. Let's jump right into today's explainer. If you're entering the medical billing and coding profession, you are absolutely going to be seeing a lot of Medicare patients. So today, we're going to decode the complex alphabet soup of government healthcare coverage, giving you the tools to process these claims with total confidence.
Here is our blueprint for today. First, we'll cover the foundation of Medicare. Then we'll break down Parts A and B, followed by Parts C and D. After that, we'll look at supplement policies and finally wrap up with some key administrative rules.
All right, Part 1, the foundation of Medicare. To really understand how to accurately bill Medicare, we first need a quick look at its origins. It was established way back in 1965 as part of the Social Security Act, originally designed to cover medical expenses for seniors. Today, it's a massive program, serving as the chief government health insurance payer and the ultimate benchmark for all commercial billing. Now, what's really fascinating is how a program this huge actually gets funded. It all comes down to payroll taxes, specifically FICA levies. These are deducted from practically every working American's paycheck, with contributions split between the employee and the employer. So you pay in over your entire working life, but you don't actually reap the benefits until you meet some strict qualification criteria.
As a medical coder, you're going to be dealing with 3 specific patient demographics. First, legal U.S. residents who are 65 or older and have paid those FICA taxes for at least 10 years. Second, individuals with a qualified, permanent physical or mental disability. And third, patients with end-stage renal disease who are either on dialysis or waiting on a transplant list.
Moving right along to Section 2, Medicare Parts A and B.
This right here is absolutely crucial. You have to know the strict separation between these two parts. Part A is what's funded by those payroll taxes we just talked about. It covers inpatient hospital care, short-term skilled nursing, hospice, and some home health care. But here's a golden rule for coders. Just because a patient spends the night in a hospital doesn't automatically make it a Part A claim. They literally must have been formally admitted by a physician. On the flip side, Part B handles elective outpatient care, physician visits, preventive treatments, and durable medical equipment.
Now, patients definitely aren't off the hook financially when it comes to Part B. Unlike Part A, Part B requires a monthly premium. Plus, patients are responsible for an annual deductible and a 20% coinsurance for any covered treatments. Once that yearly deductible is out of the way, Medicare covers 80% of approved expenses, leaving that remaining 20% to the patient. Knowing this is absolutely vital for your front office when it comes time to collect balances.
And this is where a simple misunderstanding can really hurt a patient's wallet. Because Part B is elective, some folks decide to delay their enrollment. But if a patient is no longer working and misses their enrollment window, Medicare hits them with a steep 10% annual premium penalty. Sure, if they're still under an employer's group health plan, they can defer without a penalty, but knowing these nuances helps your team navigate some really tricky patient conversations.
Let's move into Section 3, Medicare Part C and D. Some patients decide to opt out of the traditional original Medicare and go with Part C, which you'll usually hear called Medicare Advantage. In this setup, Medicare pays a predetermined monthly amount to private commercial insurance firms. In exchange, those private companies administer a replacement plan that covers everything in Parts A and B, and sometimes they'll even throw in extras like vision or prescription coverage.
So why does this matter to you as a coder? Well, Part C plans play by their own managed care rules. You have to verify Part C enrollment early on, or you risk violating network restrictions or referral mandates. A Part C plan can literally force a patient to only see in-network doctors or demand strict specialist referrals. If you process that claim using standard Medicare rules, you're looking at an instant denial.
And then we have Part D. This is specifically for prescription drugs, and it's also managed by private organizations approved by Medicare. Now, you might not deal with Part D claims directly all that much in a medical office, but you will definitely need to politely remind confused patients that their Part D card isn't a secondary medical plan for their office visit, it is strictly for the pharmacy.
Up next, Section 4, Medicare Supplement Policies.
Before every single patient interaction, this is the exact question you need to be asking when you check a patient's secondary coverage. Since Original Medicare only picks up 80% of those approved outpatient expenses, a lot of patients buy a supplemental policy.
You see, a true Medicare supplement, often called Medigap, is strictly gap coverage. It bridges the gap for out-of-pocket costs by picking up that 20% coinsurance, and sometimes even the yearly deductible. But here is the critical limitation.
If Medicare outright denies a claim because a procedure wasn't deemed medically necessary, that supplemental policy is not going to magically step in and pay. It only covers what Medicare actually authorizes, but doesn't fully pay for.
Finally, let's dive into Section 5, Key Administrative Rules.
At the very top of the food chain, we have CMS, the Centers for Medicare and Medicaid Services, setting the national rules. But your day-to-day relationship for getting claims paid is handled locally. CMS contracts with private regional businesses known as MACs, or Medicare Administrative Contractors. They're the ones actually processing your Part A and Part B claims on the ground.
Now, because MACs are regional, they actually have the power to create their own local policies when CMS hasn't set a national rule. These are called Local Coverage Decisions, or LCDs. This is huge for you. If you're billing a code subject to an LCD, you have to check your local MAC's guidelines. A diagnostic code that justifies a surgery in one region might be completely denied by the MAC in your region.
So what do you do when you know an LCD restriction means Medicare probably won't pay for a service? Enter the ABN, the Advanced Beneficiary Notice. It's essentially a waiver of responsibility. It ensures doctors are completely upfront with patients when a treatment might not be covered, warning them that they'll be on the hook for the bill.
The absolute golden rule for ABNs? Timing. It must be signed by the patient prior to receiving the treatment. You can't just use a generic blanket signature form either. If you skip these steps and fail to get that signature before the service is provided, and then Medicare denies the claim, the patient is off the hook, and your provider has to eat the...
So the next time a complex Medicare claim lands on your desk, ask yourself, are you just blindly entering data, or are you strategically navigating the system to protect your practice's revenue? Please like, share, and subscribe to Decode Healthcare with Harshal.